the group wants to know approximately how many patients with scleroderma are currently being seen at MUSC, and then what percentage of those patients are, of rheumatology patients are scleroderma patients here?
So I asked my colleague, Dr. Oates, to use the electronic medical record, which I'm not very good at myself, to run some numbers. And he tells me that in the past 6 months, the rheumatology division has seen about 565 individual patients with scleroderma. So you can sort of do the math in terms of how many we see per year. And this makes up about a little bit less than 10% of all the patients we see in the rheumatology clinics. So that means that we're seeing a large number of scleroderma patients, and 8% is really a high percentage. If you would go to most academic medical centers and ask them what percentage of all of their patients have scleroderma, it would probably be 2% or less. So we're fortunate that we've been a center for 45 years now, and unfortunately there are not many other centers in the southeastern United States. There's some excellent rheumatology programs in Georgia, North Carolina, South Carolina, Florida, but none of those programs, whether it's Emory, Vanderbilt, UNC, Duke, what have you, they're not particularly inclined to study scleroderma. Their expertise is in other rheumatic diseases. So that means patients come, C cuts out, and come from 5 or 6 different states. So how many, let me just see, how many patients are from North Carolina, Georgia, South Carolina, okay. Charleston, South Carolina. Downtown Charleston, no. So, and occasionally we'll have patients who come to this conference from Florida, East Tennessee, and we do see patients from Alabama and Southern Virginia as well. We're glad to be here. We wish there were more centers. And when I give my presentation, part of it will be about the fellows that we train and where they go, and one of our missions is to train people in treating patients with scleroderma, and they go off and get a real job, and they're working in many other states. So I think expert care, expertise in scleroderma is becoming more readily available, whether it's Charlotte, Asheville, Atlanta, what have you.
So this is for Dr. Deanna Baker-Frost. What causes scleroderma?
So the way we typically explain it when we have someone that's been recently diagnosed with scleroderma is that autoimmune diseases is a combination of different factors, and we work very hard here at MUSC to try to nail down what predisposes people to get scleroderma. So currently what we believe is that there is some type of genetic predisposition, meaning that there's something in your genes that may put you at an increased risk of developing this disease. And then sometimes people come in contact with something in the environment. There's several things that's been known to cause people to have scleroderma. Come in contact with certain chemicals will cause people to develop it, but sometimes people don't have any known kind of environmental factors that causes them to develop it. So right now we think it's a combination of environmental triggers and some genetic predisposition that kind of comes together, and this is the way that the disease develops. And that's the current theory for most autoimmune diseases. We haven't been able to nail down exactly what the trigger is for everyone, but as I said, that's a pretty high focus of research in the scleroderma field.
Right, thank you. This is for Dr. Kate. Is there a cure for scleroderma? Can diet changes cure? Are doctors getting closer to a cure?
So unfortunately, the answer to the first question is no, not yet. We're working on it. Dr. Fagali-Boswick's probably working the hardest on it back there. But no, they, this is why we do the research that we do here at this center, as well as the research that's being done really across the country and, in Europe. And we have multi-center trials that are going on, trying to certainly help us care for our patients with scleroderma, but also trying for a cure. So I know it is a, it's daunting when someone gets a diagnosis of scleroderma that we're not able to provide a cure for it. But what I often tell my patients is that our goal is to be able to help you live with scleroderma so that it becomes a chronic condition that you can live with. So we might not be able to cure it, but our goal is to be able to for you to be able to live with it and give us more time to hopefully work towards developing a cure for the disease. In regard to the diet changes, this is a very sort of hot topic, area of interest right now. People, you go out, you look online, there are all these diets out there, the anti-inflammatory diet, gluten-free, keto, all those things. I think right now there's not enough science behind them. There's not enough data or evidence for us to come down on one side or the other and say, yes, this diet works, no, this diet doesn't work. So in general, kind of my advice to people is that, certainly if it's a diet that's within reason, to try it. And, if you see some benefits in your symptoms or something like that, if it helps you, then great. If not, then, you can sort of say, well, I've tried that. But as far as a dietary cure for the disease, unfortunately not.
Thank you. This is for Dr. Deanna. Do more women than men have scleroderma? Are there specific differences in how scleroderma affects men versus women?
So this is a very interesting question for me personally, because I have dedicated my career to studying how estrogen affects scleroderma. So the first question, do more women than men have scleroderma? And the answer is yes. Typically, the ratio is somewhere between 8 and 10 to 1. So 8 times more women will develop scleroderma than men will. And we're currently trying to understand why that happens. Typically, women develop scleroderma around the times when they have high estrogen levels, like they're going through puberty and those types of changes are happening. And so we think that maybe estrogen is playing a role to leading that development of scleroderma. So yes, women have more scleroderma than men. Unfortunately, when men do develop scleroderma, they typically have a more severe type of the disease, so they tend to have more internal organ involvement and have typically more issues with the disease when it does happen.
Thank you. Back over to. How will you know that you have scleroderma? Will scleroderma show up in your labs?
So I always tell patients that that scleroderma is a clinical diagnosis, and what that means is it's made at the visit, in the exam room, based on our physical exam, symptoms that you're having, signs that we see when we examine you. We often do blood work, as I'm sure most of you who are our patients know. We're always getting blood, but the labs can help us support the diagnosis of scleroderma, but really I try to emphasize to people that this is a clinical diagnosis. Because I know all of us up here, as well as the other physicians in the room, have had patients who've come to us that the diagnosis has been maybe missed because they didn't have the blood work or something like that, and other doctors weren't comfortable making the diagnosis because they didn't have the lab markers. But really what we're taught and what we try to, to educate our patients on is this is a clinical diagnosis. And so we really make it during the office visit, and our labs help sort of support that. So talking a little bit more about the lab, so will scleroderma show up in the blood? Most patients with scleroderma have a blood marker called an ANA, or anti-nuclear antibody. So the vast majority of scleroderma patients will be positive for that. That particular test is not specific for scleroderma. Actually, most of our patients with other rheumatologic diseases will also have a positive ANA, like our patients with lupus, some of our other patients with dermatomyositis, even sometimes patients with rheumatoid arthritis. And there are certain other conditions like thyroid disease and certain things that sort of fall outside of the diseases that we see that can also cause this positive ANA. So while it is present in the vast majority of patients with scleroderma, it's not necessarily specific for the disease. There are certain other blood markers that we do check. Usually the main three that we will check are an SCL70 antibody, another one called an RNA polymerase 3, and another one, the last one, an anti-centromere antibody. Those are what we call scleroderma specific autoantibodies. Again, these sort of aid in the diagnosis, and they sometimes can help us sort of characterize your scleroderma better. For example, the anti-centromere antibody is more associated with the limited form of the disease, whereas the SCL70 and RNA polymerase 3 usually go along with more skin involvement. So they kind of help us give us a snapshot, or almost, or really to help characterize the individual's scleroderma, but they don't necessarily make the diagnosis. And then there are more specific scleroderma-specific autoantibodies than the three I listed. Those are the main three, and the three that we test for most commonly. There are there's 6 that are commercially available. There are 9 total, I think. The other 3 that aren't commercially available can only be done in research labs such as Dr. Fagali-Bossi. But again, the main point I think with these 2 questions is that this is a clinical diagnosis. The labs help us, but they don't make the diagnosis. Children. I don't get to give up the mic yet. Yes, children can have scleroderma. It is as you know, it's a very rare disease in adults. It's even more rare in children. It's extremely uncommon in the pediatric population. What we see in pediatrics, the more common type of scleroderma in children is actually something called localized scleroderma, or morphia. That tends to have skin involvement. It does not tend to affect the internal organs like the adult form of scleroderma does, like systemic sclerosis or systemic scleroderma. That being said, if the skin involvement is depending on the location, it can sometimes be on the face, it can sometimes be on a limb or over a joint, and can certainly affect cosmetics if it's on the face, growth and limb development, depending if it's on an arm or a leg for children. And so, but it's more of an issue with those things rather than a life or death from this localized scleroderma or morphia. And then, so that is the more common presentation of scleroderma in children, but children can also have the systemic form of the disease, and I do see patients with that. Not that many, but of course it's very serious when a young person gets a disease like this. So I have a couple of young patients that come from as far away as Northwest Illinois, Texas, to come see us here at MUSC. Because as hard as it is to find an adult doctor that takes care of scleroderma, you can multiply that by about 1,000 for trying to find somebody who knows about pediatric scleroderma.
So, does Raynaud phenomena have always occurred with scleroderma?
So 99% of patients with scleroderma have Raynaud phenomenon. It's either before they are diagnosed with scleroderma or at the time of diagnosis.
Can you discuss scleroderma and intolerance to cold weather? Does this intolerance increase over time?
Okay, yes. So definitely patients with scleroderma are intolerant to cold weather because of the Raynaud, right? Because it happens whenever you're cold. And this intolerance does increase over time. There is impaired flow in the vessels, and Raynaud phenomenon can become even more prolonged, lasting 30 minutes, and can cause a lot of pain and other problems like the ulcers.
Deanna? Well, that's not. Scleroderma has decreased circulation in the fingers and toes. Do you think that there are issues with decreased circulation all over, meaning the body stays colder as the blood flow is impaired? Is there a systemic narrowing of blood vessels?
So as Dr. Ward mentioned, there is some impairment of the blood vessels, and we can readily see that happening when we see the active Raynaud's happening in your fingers and your toes. But scleroderma doesn't affect just the blood vessels in the fingers and toes. It can affect blood vessels all over the body because we have cells that line the blood vessels in the body, and those cells unfortunately don't work as well as they should. So we've noted that you have problems with blood vessels, unfortunately, everywhere. Not necessarily that the body stays colder, but that because the blood flow doesn't get to the extremities like you need it to, that the extremities get colder over time. So it is fair to say that it's systemic, meaning that it affects all the blood vessels, not that it's preferentially affects just the blood vessels in the fingers and toes. All of the blood vessels throughout the entire body is affected because the cells that line those blood vessels are affected.
Can you discuss the relationship between scleroderma and pulmonary arterial hypertension?
So patients with scleroderma who develop pulmonary arterial hypertension usually have limited disease, and like Dr. Silver mentioned, it's usually associated with the centromere antibody, and it is a late complication of scleroderma in these cases. And it usually affects 10 to 40% of patients with scleroderma.
Okay. Does a person with scleroderma always die from this illness or as a complication from this illness?
No, not necessarily. That's kind of getting back to one of the questions I answered earlier. So while we don't have a cure for the disease, it is our goal to get our patients to live with this disease. And there are patients there are patients in this room that have had scleroderma longer than us on stage have been alive, which is that's pretty awesome to be able to say that. And that would, we can't cure it. It never necessarily goes into remission, but if you've had scleroderma for that long, I mean, I would consider that beating the disease in a way. The fact that people have, are living with it 15, 20, 30 years. And specifically with the limited scleroderma, those patients can often have sort of, they, not always, but can have a milder course. And those patients often will, pass from other things, whether that be old age or, and not necessarily die from the scleroderma itself or a complication of the disease. So I'm glad to be able to answer this one and know that is not always the case.
Deanna? how do I get this disease and no one else in my family has it?
So that kind of goes back to the original question of how do we get scleroderma in the first place? And so, as I mentioned before, we believe right now that it's a combination of genetic factors and environmental influences. So most times, there is a genetic predisposition, meaning that there's something in your genes that make it more likely for you to develop scleroderma, and often an environmental trigger happens that kind of sets that off, and then you develop scleroderma. So the likelihood could be present throughout your family, but due to kind of differences in how we interact with the environment, or different chemicals or different places that we've gone to, may have allowed certain people to develop scleroderma, as opposed to other people who may also have the same genetic predisposition or the possibility of developing scleroderma, but because they didn't have, the exact same lifestyle, or, gone the same places we've gone to, or, seen the things that we've done, or things like that, they may not develop scleroderma. So it's a very complicated question, unfortunately, but it's something that we see very often, that sometimes, a person could be the very first person in their family and no one else in their family has it. And then conversely, we can see, of several generations of people that have had different and various types of autoimmune diseases, not just scleroderma. So it's definitely possible that there could be kind of one person that's the outlier, quote unquote, that developed the disease and other people didn't. And so we think it's, like I mentioned before, an interaction with the environment and genes that causes that to happen.
How often does Sjogren's syndrome overlap with scleroderma? Do your antibodies have to be positive for the two to overlap?
So Sjogren's syndrome can be seen with scleroderma. It can be seen separately in a disease all by itself, or it can be seen with other autoimmune diseases. And typically what we think of with our scleroderma patients is you have significant dry eyes and dry mouth that goes along with the disease. And so that's one of the manifestations that we see with Sjogren's syndrome. And it typically happens just because, there's an impairment of the amount of saliva and the amount of tears that's being produced as a byproduct of the disease. You don't necessarily have to have the quote-unquote positive antibodies, like the SSA is one of the antibodies, SSB, that we look for when we diagnose someone with Sjogren's syndrome. Sometimes patients with scleroderma may or may not have those antibodies, but they still have a significant amount of dry eyes and dry mouth that go along with it. So you may not have the positive antibodies, but you still have a lot of the SICA symptoms, is what we call it, the dry eyes and dry mouth.
Can you discuss the connection with celiac disease and scleroderma?
So oftentimes patients with scleroderma have a lot of GI manifestations, which is a segue into when our later speaker will come and talk about GI manifestations with scleroderma. There's not necessarily a connection between celiac disease itself and scleroderma. Oftentimes when patients have autoimmune diseases, it predisposes them to get other autoimmune diseases, and so they can come in clusters. So celiac disease is an autoimmune disease that is a gluten impairment, so you can't digest gluten properly. And so that's an autoimmune disease that can happen with scleroderma, just as lupus can happen with scleroderma, or autoimmune thyroid disease can happen with scleroderma. So oftentimes they cluster together, and so there's not necessarily an association with celiac disease itself and scleroderma. However, we all know that scleroderma patients can have difficulty with digestion and difficulty with kind of GI manifestations. That's unfortunately pretty common.
Celine? Does scleroderma increase the risk for skin cancer? If so, is it just in the areas affected by the scleroderma?
So scleroderma does not increase the risk of skin cancer. So it is associated with certain cancers, such as lung cancer, and it's usually patients who have a certain type of antibody, the RNA polymerase III. But specifically, the skin cancer risk is not increased in scleroderma. So the second question, so No.
Deanna? Are there any natural remedies or holistic treatments for scleroderma such as CBD oil?
So I kind of did a little bit of investigation last night, looking at this question a little bit more closely. So again, unfortunately, there are no FDA-approved medications for scleroderma yet. We're working on that. And so the question always is there any natural things that can be done? And there have been several small studies that have looked at using vitamin E oil on the skin, evening primrose oil on the skin, and patients report to have more flexibility of their skin and things like that. So that has been reported in the literature. We often make sure our patients are vitamin D replete. So we, want to make sure that you have proper amounts of vitamin D in your system as well. Specifically, there has not been any studies using CBD oil itself with scleroderma and to see how that helps, improves the disease or not. So I cannot answer the question with CBD oil, but specifically evening primrose oil, vitamin E oil, and we always do vitamin D supplementation are the ones that we typically have seen to have some improvement. And again, these are all just very small trials, all case series, which means that they've done in a very small number of patients. And so some patients may have gotten benefit from it, other patients may not have gotten benefit from it. So we always recommend before you try any natural remedies or you're thinking about doing any holistic medications, just talk with your doctor about it, just so that they can make sure that those medications or those remedies wouldn't interact with any of the medications that you may or may not be taking.
Kate? Can scleroderma patients have facelifts, and if so, how successful are they?
Yes. There's not a contraindication to cosmetic procedures such as facelifts or other procedures in scleroderma patients necessarily. And in certain of our diseases in rheumatology, typically more like lupus and some other ones like that, we and the surgeons worry about things like wound healing. In scleroderma, it's actually an overproduction of collagen. The skin produces too much collagen, and collagen is actually what sort of helps your skin stay tight and elastic. So with the collagen that's produced in scleroderma, you should not actually have any issues with wound healing. Now, there are certain medications that some of our scleroderma patients are on, like immunosuppressant medications like Cellcept, mycophenolate, Myfortic, Imuran, things like that, that should probably be stopped several weeks or several days prior to a surgery. That's why to echo what Dr. Deanna Baker-Frost said, if you are considering something like this, you would want to let your scleroderma doctor know so that they can advise you if there are any medications you need to stop, and then also certainly letting your cosmetic surgeon know about that as well. And I would think that they would be just as successful as a facelift on somebody without scleroderma.
Can I receive, this is for Kate, can I receive injections or laser treatments for spider veins in my legs?
Yes, again, there would be really no contraindication to most of the treatments that they do for spider veins and laser treatments and things like that. A lot of the dermatologic and those cosmetic procedures, there would be no contraindication. Or scleroderma would not be a contraindication to that. But again, just let your rheumatologist, let your scleroderma doctor know so they can, because a lot of these procedures, these aren't our areas, and so certain ones we would want to maybe do a little bit more research on and make sure that that was going to be a safe and appropriate procedure for you to have. So just always kind of keeping us in the loop so that we can advise you on that.
Celine? I have limited cutaneous scleroderma and Sjogren's syndrome and have struggled with this for years. At the advice of my dentist, I have used Biotine, Sorry, guys. Can't say those.
Biotin, pilocarpine, 7 million.
I had 5 dental implants, numerous cavities, and gum graft related. Is there any product you know that could help me?
Unfortunately, I don't have an answer for this question. I have read a lot of articles about it. I know a great resource is the sjogrenfoundation.org. They really have some useful information in this. Dr. Silver, do you have any suggestions? It is a very... Okay.
This is for Dr. Silver. A study was performed on patients with systemic sclerosis entitled Improvement of Mouth Function Disability in Systemic Sclerosis Trial for Transplantation versus Adipose-Derived Stromal Cells. What happened with this trial? Is this treatment available?
So I'm not sure which trial this question is referred to, but I have seen the results of a study that was done in Great Britain, in London, where adipose-derived cells were injected to the face, and they were looking at facial appearance, from a cosmetic point of view, and as well as ability to open the mouth, the oral aperture. And the first thing from this study, which is not yet published, was that it was a safe procedure. There weren't any significant complications. And the investigators' conclusion was that it was helpful for some patients. Most of these patients had very late systemic sclerosis and found it to be helpful, mostly from a cosmetic point of view. So this is an area, and maybe the next question is related to this.
Yes.
Right, so this is an area that's really rapidly evolving. So most patients, as we heard, will have Raynaud's phenomenon, and many patients will develop digital ulcers. And these are very painful, and everybody's nodding their heads. And these heal very slowly. And so we typically prescribe medications that are designed to increase the blood flow to your fingers to help heal these ulcers. But even with these medications, it's still a significant problem for many scleroderma patients, and it really impacts their quality of life. So there's interest in using stem cells. Now, if you open the newspaper, you'll see ads for stem cell therapy for just about everything. I usually, in my general rheumatology practice, somebody every week asks about the utility of stem cells for their osteoarthritis of the knee. And there are people out there that will do these procedures even though they're not FDA approved. They're in many cases, not even likely to be effective. We see patients who, if on their x-ray, there's bone on bone. There's no cartilage left. And yet these people are willing to perform these procedures for their financial value that they derive from it. But so there's a lot out there on stem cells that you have to be very cautious of. Having said that, this study was done in the US after a study had been done in France. And what the way the study, so there have been 2 studies, and then I'll tell you about a third one. The idea here is to do a limited liposuction. A lot of our patients are eager to have that done. And then the adipose material is put through a centrifuge, spun down, and a portion of that is then taken, and that contains cells that are called stem cells. Sometimes they're called mesenchymal stem cells or regenerative cells. They go by various names. Those were then injected into the finger, all 10 fingers. And they were looking to see about healing of the digital ulcers. The first study done in France was a positive study. So then the company which owns the machine, it's not a drug study, it's a device study, that company called Cytori sponsored a clinical trial here in the US. And it was well designed because half the patients got the adipose cells and the other half got a sham procedure. So they went through the whole, they got the liposuction, but instead of injecting the adipose cells into their fingers, they had saline injected into their fingers. And then when they compared the two groups, unfortunately, the adipose injected patients didn't show as much benefit as was expected from the earlier study. So they didn't reach their endpoint, and actually I don't even know if the company is going to do another study. But then at the 5th World Scleroderma Congress, which was about a year ago in Bordeaux, a group from Italy presented their results, and they were very positive. So the patients who got the sham procedure didn't improve. Patients who got the adipose-derived cells improved dramatically. And then the patients who got the sham procedure could then get the real procedure, they also improved. So I think there is something to this, that these mesenchymal stem cells might be a way of regenerating tissue or leading to new blood vessels that would facilitate the healing. So unfortunately, we don't have an answer. I think you have to be very careful about what's being done in the community, but I think this is potentially very promising.